Hi, my name is Jen Lowther, and I'm at the Institute for Innovation and Implementation at University of Maryland School of Social Work. And this is our fourth opportunity to meet together as a collaborative. We started meeting every other month in January. So I appreciate everybody coming to this meeting in July. And just to get us started, if you wouldn't mind in the chat putting your name, organization, or agency, the county in which you work, and any just a fun question to share any fun favorite barbecue food now that it's a little cooler out. You can get out there and grill without melting yourself. So just for fun, if you want to do that, please enter into the chat. There appear to be a bunch of folks with their hands raised. Do you want to put your questions in the chat? Or if they're questions for Tiara, you can text her directly. We'll be using the chat as our means to collect questions and answer them as we go along. And I will move to the agenda so you can see we have a pretty full agenda. So we want to keep the questions rolling as we go through each of these items with the BHA update, a best practice check-in. We're focusing today on the someone to respond component of a crisis response system, the first of three parts of this. Then we'll have our local presentation from Calvert County, move into regional breakouts. You will, Tiara will put in the grouping that you will go to depending on your county that you reside in or work in. Then we'll have an update on data collection outcomes and a CAT update, and a quick brief update on TA training to date, and any questions at the end, and make the resources available. So that said, I think we will probably move into our first presenter, which is Maria, and I will pass the torch to you. Thank you.
Sure. Well, thanks everybody for joining. I'm watching the chat and seeing all sorts of familiar names popping up, and a wide variety of places people are coming from and representing, and it's really thrilled to see everybody continuing to come to these events, you know, every couple of months as we're holding them, and, you know, seeing how far and fast we're moving with this effort. So go on to the next slide. We can go in and talk about some of the implementation updates that we want to be sharing. Maybe before stepping into workforce requirements recommendations, just to make note of the fact that we are getting a couple of more big boluses of funding out the door. We're in the final stages of signing, and some of those I know have been passed over to the counties now. So there should be some big expansions coming through, and people really being able to see that in the next few months. So we've been working diligently with Medicaid and with our consultant partners around, you know, what are the recommendations for these specific teams? What are those requirements? You know, obviously we're having to rewrite and update come our regs. That's not out yet. When it is, we'll certainly open that up to the, you know, greater workforce community and, you know, our stakeholders as well. But we're getting to the final place of that, but certainly there's some things we can talk about and share at this point. So obviously mobile response and stabilization services, we need, you know, the team members for those services. So required roles are the mobile response stabilization workers. And there've been some, you know, clear guidance coming out from CMS around licensure and non-licensed, not independently licensed clinicians, not licensed clinicians. So your graduate level staff, your community behavioral health staff, your peer staff. And so we're laying out some of the rules and expectations around that. Required role is a licensed supervisor, so that if you have these non-licensed staff out as part of your team, you need to have a licensed supervisor available to be signing off, to be overseeing, to be providing that appropriate guidance and supervision as is required by, you know, the different potential licensure categories. And then a psychiatric consultant. This is best practices, ideal to have this, particularly as we're building this in the child space. MRSS, you know, is the gold standard model for children. We're trying to bring this lifespan to the state, but certainly the psychiatric consultant is a piece of this. I do want to take the opportunity to just sort of highlight what do we have potentially available. We know this is a costly role. And so what is the state able to do to support this? As areas are coming online, setting up teams may not have this up and running yet, as particularly in some of our rural areas where, hospitals don't necessarily even have these resources, particularly in the child space. We do have, expanding relationships and contracts with BHIP TP providing consultation support. Not every case is going to need consultation with a child psychiatrist, but when somebody does need that, when somebody really has a question about, am I missing something? Is there something here? Something feels concerning. Those resources are available through the general BHIP line. Let them know you're calling from a crisis situation. They're tracking that, and they can get you to pediatric specialists all the way up to the child psychiatrist level consultation. Optional roles within the workforce and the teams that are being set up is having some compliance and data management responsibilities, and then obviously having some responsibilities over training management. Again, in these areas, states taking a lead, helping lay out what is expected. That's coming to our locals in the contracts we're setting up with the locals. They're then bringing that language into the RFPs they're putting out, into the expansion contracts when that's what's going on in a particular region. But those elements are being, spelled out and specified, again, consistently across the entire state. With that, not noted on here, but I do want to also reinforce the consistency of an assessment tool. Again, in the child space, it's the CAT, and the adult space, we're leaning towards something very much aligned with that consistency, getting data that's across the whole state, getting data that's allowing us to really say, what's the impact we're having of this? All right, going forward, next slide. Going in a little bit more around that direct care staff, what's happening, what's that look like? Teams need to be available for response 24/7, 365. Again, that doesn't mean you have to have your whole team sitting there in an office overnight waiting for the calls to come in. There are some flexible options for this. There are ways of using an on-call beeper, sharing some of these overnight resources across broader regions. There are ways to help make this cost effective, but the expectation by both this model and by CMS guidelines for taking this to Medicaid is that it's a 24/7, 365 availability of a response. Expectation, best practices to provide mobile response and stabilization services. At the moment, we're looking at the 72-hour as being part of that mobile response continuum. And then stabilization would be anything that's needed after that, probably being billed out in and getting an authorization for short chunks, and working through that. The details of some of this are being ironed out with Medicaid, but that's the way we're heading. That's the models we're looking at. Education experience required. Here's a big piece to be very much aware of, the sort of flexibility with this. Master's level mental health professionals with or without licensure. Again, we talked about the supervision. If somebody doesn't have the license or they're in process of getting it, you can be using that supervisor, that license level person as a component of a team, not necessarily having to go out on every call, not necessarily having to do face-to-face, but they can be providing that backup and supervision from a different location. Bachelor's level human service professionals, they can be part of this team. Caregiver peers can be part of this team. Family peers, we talk about that model a lot in Maryland, and that is certainly a component of the team. They can be part of the immediate response team. They can be part of that 72-hour follow-up component. They can be part of that longer stabilization component, but they're an essential part. And then youth peers. Obviously, we're not sending out the 13-year-old peer to be responding to the 8-year-old, but young adult peers can be part of a response team for this as well. Personal traits and training are more important than degrees obtained. And I think this is a take-home message of all of this, which is we really want to be training these people. We really want to be getting them up to speed, helping them understand this sort of crisis de-escalation, stabilization type model, the child and family team component, the idea of responding in that manner. That all is stuff that can be coached and taught to individuals that are interested in learning and interested in gaining these skills, rather than necessarily being the requirement of a specific degree that has been obtained. So next slide. MRSS supervisor, we talked before a little bit, expanding on that. They have to be available for support and consultation. You have to have somebody available all the time, available to dispatch in person or virtually for complex needs and coverage gaps. So again, some of this can be provided through us for the psychiatric, the BHIP level, but within the team, you need to have somebody that is, eligible by licensure to be a supervisor if those individuals that are going out in response to a call don't have those qualifications. Minimal education and experience being required. Again, master's level mental health professionals as a supervisor. We want to see that level of training being available as a supervisor. Need to be independently licensed to practice in Maryland. Licensed as an LMSW or LGPC if you have the supervision of those individuals available behind the scenes. With, again, that access has to be 24/7, 365. I think there's some questions coming in, and maybe we can collectively answer those at the end. So then next slide, Jen, or whoever's moving it forward. Expanding on the psychiatric consultation, talked a little bit about this. They have to be available 24/7, 365. Doesn't mean you need to have a full-time person for every team that's being set up or every program. We can be providing some of this through the state as things get built up and you have a little more need, a little more volume. Programs can start to look at, hiring somebody part-time or sharing services with a neighboring region. Again, experience being available, board certified child and adolescent psychiatrist. Given today's world, probably going to have to say board eligible, board pending, all those kind of variabilities we need to do. Licensed psychiatric mental health nurse practitioner. Again, they're a physician extender. They're essentially equivalent at this point. Having experience in the child and adolescent space. And then access to a supervisor for them, within the requirements of their licensure. Again, doesn't need to be a full-time, can be a contracted service. And for the startup period, the short term, we're using, the available resources we have under BHIP to do that. Don't want to flood them, don't want to swamp them, but they are available as programs are getting off the ground. Next slide. Okay. The optional roles, we talked a little bit about the need for compliance, for data, for monitoring, for this ongoing quality work, improvement work. Depending on the size and the needs of programs, these duties can be fulfilled by a supervisor or other existing roles. But we need to be having and tracking some of these issues, and they're going to be written into the contracts that have gone out to the regions, the locals, and then from those locals to the potential vendors. Consider whether these important duties can be completed with regularity and competency given other responsibilities. So as volumes for programs pick up, somebody may not be able to continue to wear 3 hats, and you may need to bring in another individual to help and assist within these roles. Next slide. Okay. CMS guidance to state health officials. And this is the CMS, the regs in terms of the Medicaid guidance on the scope of and payments for qualified community-based mobile crisis intervention services. So that's a link to that document. Again, the state is using this quite extensively in terms of laying out where we are putting out best practices, recommendations, guidelines, as well as the COMAR regs that are being developed at this point.
Great. I think that's your last slide, Maria. There are some questions about BHIP. Thank you, Heather Dewey, for putting in the link to BHIP. And there was also a question about peer requirements in there. Do you want to answer those now, or?
I can confirm that the BHIP is Monday through Friday. So obviously, if somebody's responding on a weekend, and there is issues, there may need to be that information resource brought in on a follow-up stabilization, the secondary part of a crisis response or a stabilization response. And then work requirements for youth peers. I think that may be a place where we need to follow up on that. Work requirements, I don't know whether you're alluding to somebody being too young to be working, where I don't think I'd want them being a youth peer, or there's something else I'm missing in the question, but we can follow up with you and understand that question a little bit more, unless somebody else gets the nuance of what's being asked.
Yeah, Tina, we can get you some more specifics about those requirements, work requirements. Sure. Okay, great. Well, I think we'll move along to Liz's presentation, and we can always circle back on questions at the end. And as they come along in each section, please put them in the chat. We'll find a way to answer them as we go along. Thanks, Liz. Thanks, Maria.
Okay. All right, so my job today is to talk about the best practice of someone to respond. For those of you who don't know me, my name is Liz Manley. I'm a senior advisor at the Institute for Innovation and Implementation. I'm also the former assistant commissioner for New Jersey's Children's System of Care, which has had mobile response and stabilization statewide since, well, for over 20 years. And so today I get to share some of those experiences, but for folks who don't know, I also provide technical assistance across the country around lots of different topics, but mobile seems to be a very important one these days. So if we go to the next slide, Jen, that'd be great. So someone to respond. So let's just connect that first dot when we talk about someone to contact. That's, you know, a parent, caregiver picking up the phone, calling and asking for help. And that calling and asking for help leads us to say, okay, parents are experiencing something that's important for us to pay attention to. Because it's something that we should pay attention to, we're going to send somebody on a team to go, right? And what that team looks like is really important. And as Maria talked about, some of the you know, some of the workforce challenges, but also some of the opportunities to get training and support in for, you know, by using, as an example, bachelor's prepared folks and peer support partners within this work is something that we're seeing as best practice across the country. So in this someone to respond, we want to talk about that single point of access, right? That place in which parents connect with it. And that the team goes, and that team goes within most states, it's within 60 minutes, they're actually on site, with the exception of Connecticut, which is 45 minutes, because they're a small state and seem to be able to do that. New Jersey is 60 minutes and has been 60 minutes for a long, long time. There's a 72-hour component, as I think you all know, we've talked about that before, and then there's the 8 weeks of stabilization. And in the initial response, we want to talk about some practice guidelines, some real ideas about what you can do within that 72 hours and some of the tools that we might think about using. So the next slide, Jen. And you could just keep going till the end of this because I think it's delayed. Yeah, so this slide depicts how it all fits together. Right? And it's just really important for us to understand that when we talk about mobile response and stabilization, that although there's these other components, and some folks use other components, right? Some folks organize those components in a way that's different. The goal is for these components to fit together in a way that is seamless for children, youth, and families. So that's someone to contact, the team, dispatching. I'm going to talk a minute about triage in a second. That team going and actually, you know, arriving at the family's home is just really important. And whether it's at the home or someplace in the community, it is really important for us to understand what families are thinking and where they would like us to meet with them. Where do they feel most comfortable and having these particular conversations? And in that someone to respond, what we're talking about really is the family having already defined the crisis. Now we're talking about that screening tool or the crisis assessment tool. And we're talking about thinking or planning for home and community-based services, really with a focus on making sure that young person returns to school and gets back to school safely. We're talking about safety plans and planned respite as some of the tools, and we'll talk a little bit more about that. I do want to talk just briefly around the triage, right? So as we have someone to contact, right, that available 24 hours a day, 7 days a week, there's someone who is answering the phone. And in that triage, right, in the adult triage, there's a conversation that happens and sort of a weeding out of whether or not teams are going to go or not go, right? That's what happens in the adult world, because adults have a lot of control over what it is that they need. They're calling for a purpose and a reason. When it comes to families who call, when it comes to parents who call, what we have learned from a lot of parents across the country is that if we screen those parents out, if we triage them out and say, you know, we're just going to talk you through this over the phone, when they really aren't ready for that, it becomes really challenging for families. But what's also important in this conversation about triage is that really our conversations are about how do we make sure that it's safe for the team to go into the community. That's really what we're trying to do. We're trying to get there within 60 minutes anywhere within the state. And that really is the best practice. And the reason it's the best practice, let's just think about this for a second, where a parent of a child who has been experiencing challenges picks up the phone and calls the public system and says, I need help. What level of anxiety and their own challenges are happening for that family in that particular moment, that we wouldn't say, let's just go. Let's just hold your hand, help you through it, and make sure that we're providing clear support for this child, youth, and family. The investments in that work save dividends in the long term across the full scope. One other thing I want to say about triage, and that is, you've heard me say this before, I'm going to continue to say, that this idea of responding with law enforcement is one in which we really need to take into consideration why. Why would we respond with law enforcement? The goal in mobile response and stabilization is to begin to build a relationship with a child, youth, and family who are experiencing behavioral health needs. 75% of all behavioral health needs in adults start in children. If we start our relationship from a perspective of coerciveness, then that's the experience that families will have for a long time. If we start our experience from a place of help and assistance, that is the experience that families will take away in a way that's meaningful. And so our goal here is not just this particular 72-hour period of time. Our goal is setting the stage for the experience for children, youth, and young adults across their lifespan. Okay, next slide, please. Let's get talking about what's happening in that visit. So we talked about the care pathway. I just always like to make sure that folks know that we're really working hard to shift care pathways from a place of driving young people and families into emergency departments, really into helping families understand that this help can be delivered in their own homes, schools, and communities, which are really important. I heard someone say yesterday, which I just think is so true, that as a state, this one particular state is trying to help retrain parents and young people that what they had told them for years, and that is if you want to get help, you have to go to an emergency department. They're trying to change that message to say, if you want to get help, you just have to call us and we'll come. And it's a really important message for families and children to get. So this shifting of care pathways is incredibly important in the long term in terms of how that system is going to perform. Next slide, please. And these are the core components. Today, we're going to really focus on the 72-hour component, right? We've talked about the call center and the person to connect. We've talked about triage. Today, we're going to talk about that 72-hour component, face-to-face within an hour. Why is that important? Being available 24 hours a day, 7 days a week, 365 days a year seems like a really big mountain, and it is. It is challenging to get there. It is worthy to get there if you want to be able to use mobile response and stabilization to set the stage for the rest of your children's system. And that means the experience of parents further along the crisis continuum around hospitalizations and inpatient and residential care all starts with this understanding that the system is saying to parents, if you trust us, we're going to be available to you 24 hours a day, 7 days a week, so that you can trust that we will be there when you need us. And when we communicate that with families, families begin to trust us earlier. And so those calls don't come in when children are at the highest capacity of their behavioral health need. They're coming in earlier when we're beginning to see some changes. So really important for us to think about that. And that we really want to focus attention not just on the crisis de-escalation, but really this developmentally appropriate assessment where we're going to gather information on what brought us to today, what happened that got us to this time today. Next slide, please. So we're face-to-face within 60 minutes, that triage, why today? Why did parents pick up the phone and call today? The risk of recognizing that there is risk in, with a team going, there is risk in the team not going. And so we want to err on the side of keeping young people in their own homes, schools, and communities, because what's different about children and intervening with children is that if we move to too big an intervention too fast, we actually impact that child for the rest of their life. And so it's really important that we get this piece right. This is why it's important for skilled teams to go. And by skilled, I mean trained, supported, supervised, coached. All of those things are important when we talk about the teams that go. And that the goal of those teams is to build a relationship with families very quickly. And that if they're the ones on site and see something that is larger than they can handle, this is why supervision is so important. That we want to do a warm handoff, right? So we don't just go, okay, the family called and we're going to run, and we lose track of the family during that time. That warm handoff allows us to continue to communicate on our way. We continue to be able to support that family while we're going. That ability to have continuous communication is important. Not all families will want it or need it, but it's important for the ones who do. When we get there, we want to de-escalate. We use de-escalation skills through crisis intervention training programs. I was trained in Crisis Prevention Institute, was a trainer for a long, long time. These are really important skills for us to be able to walk into families' homes with. That we recognize that crisis is defined by the parent or the caregiver, and they're defining that crisis because what they're basically saying is something big is really happening and it's more than I can handle at the moment. So it's not just that the child's behavior is something that we have to consider. It is the caregiver's ability to manage that and their need for support and understanding what's happening with their child and how do they actually help their child, not just in the short term, but in the long term. And now as we think about safety planning, we want to actually include soothing plans and the ability for us to actually leave the family with some tools that help that child be able to soothe. A really important part of this work as we move forward. If the child has not been traumatized prior to this intervention, there is always potential that we are part of a system that will traumatize the child. So we need to always keep that in our scope and our understanding of what's happening from the child's perspective. And then we use that crisis assessment tool to help us figure out what it is that's going on, what's happening for that child and that family. And we want to be really aware and cognizant of suicidal ideation. The Columbia Suicide Scale can be incredibly helpful with that. But we also want to be aware that the way for us to engage and work with young people who are experiencing suicidal ideation is to figure out how to keep them as safe as possible within their own homes. Next slide, please. We talked about, and I use this tool frequently to think about and understand what's happening with young people and their families. This 24-hour clock allows us to sort of quickly see some of the challenges families might be experiencing. So if we could just figure out what's happening for the child in their own structure, right? Are they sleeping at night? Do they have time for meals? Are they good eaters, or are they picky eaters? Do they have time for family time, activities where the families get together? This is important. Sometimes you'll see shifts in family structure because, say, a parent, who was always present, all of a sudden has a shift in their job or their job schedule, just as one example, right? We might be talking about, do they have friends? Do they have a couple of friends that they spend time with? Do they not have any friends? Do they have an overabundance of friends? This is really important stuff. It's important for us to know about school and how they're doing in school. Is there a change in their grades, their attendance, or their behavior within school? Is there a shift in their physical activity? It's not uncommon for a mobile response to get called out for, for teenagers who were pretty active, who all of a sudden are no longer active. That's a really important thing for us to understand. Do they have time for study and time to do therapeutic interventions? Are these things included in their schedule? What's important about this 24-hour clock, by the way, is that it allows us to have a visual tool to see whether or not we can put other things in place and whether we need to ease some of the child's schedule or whether we need to add more things. Next slide, please. Now, I want to talk about crisis and soothing plans. So, you're all being trained and we're talking about the crisis assessment tool. A really powerful part of this work is that crisis assessment tool, that it helps us figure out how do we get to crisis and soothing plans. And I don't necessarily think that we have to always call it a crisis plan. Many of you will. It's fine with me, whatever you choose to call it. But in that crisis plan, we want to make sure that we're hitting on that soothing component to that, right? So in that plan, we want to ask the questions of why today? What was the trigger? Can we see it? Does it make sense? Did the parent call because they've been getting lots of calls from the school, or because there's been a big decline in the child's behavior? Did it get to this place where their 15-year-old won't get off the sofa and they don't really understand what it is that's going on? And we want to think about who can help. Are there other informal family members, as an example, who can come to the table? I'm from a large family. It wouldn't be unusual for me to get called into a situation where, you have a teenager who's had some changes, and what's happening, and who is there, an aunt, an uncle, friends, who else can be part of this plan? And then we think about who are the informal, right? Who are the community members we want to bring in? And then also who in the formal world, the school, the teacher, the pediatrician. Do we need a therapist in here? Do we need to bring somebody else in to help us work through this plan? And then how do you communicate? How does the child communicate when they're doing well? How do they communicate when they're not doing well? Right? How do parents communicate when they're doing well? How do they communicate when they're not, when the crisis is happening? Trying to understand that ability to communicate and reestablish that communication can be really powerful for young people and families. As an example, I've worked with many young people who in crisis situations really do well in texting and don't do well verbally. They can't articulate what's happening, but they can certainly text you, and you could be in the same room texting a young person and get a ton more information from some of them. That's particularly true of young people with developmental disabilities such as autism. And what can you do? We always want to do some grounding in physical activities, making sure that we recognize that children, youth, and young adults are children, youth, and young adults. Having them be able to have movement in their plan, really important. That there's community connections, that we address school and challenges within school. And then we touch on sensory diet, not that we're going into big jump into sensory diet, but what do we know? What do families know about how children respond to things like clothing and loud noise and colors and smells? Those are really important things for us to at least begin the conversation around. Next slide, please. Okay, so we've talked before, and I'll talk again about this idea of bringing something with you, right? As you go and respond to the child's home, having things for children to do are important, right? Whether they're teenagers or children, and whether there are other children in the home, it's important for us to have some tools in our toolkit with us. These are some of the toolkits that I think are important. Things like, weighted blankets and stress balls. You might want to bring a jump rope or playing cards, something that are going to keep young people's hands busy during the time that you're in this and going through the crisis assessment tool. paper and crayons are really helpful. By the way, journals are really helpful for teenagers during these times. You also want to think about communication tools. You might want to bring a PEX board, which is really just about pictures so people can communicate. If you're not familiar with that, certainly willing to help you in some of that. And you want to make sure that you include some, an app on your phone, if you will, for breathing exercises to try and bring young people down. Next slide, please. We want to think about technology and communication tools as we're thinking about families, right? So telehealth is an important component of any continuum these days. But when and how to use telehealth is going to be important. So when you're meeting face-to-face with families, as an example, you want to know whether or not your child does well within Zoom, whether that's been helpful or not helpful, and whether or not it is one of the things you'll include in your care plan in the long term, right? Are we going to use some telehealth technologies, or are we going to say no? Because what we do know is that there are young people who do incredibly well with telehealth, and there are some young people who don't. And so if we can get a sense of that from young people, from that parent and the caregiver from the start, we'll know whether or not that should be included in your plan. We know that some young people do really well in writing, and journals can be a really helpful tool. So we want to think about that. Smartphones, and what is the role of the smartphone within the family, within that home? Do parents communicate with each other and to their children with smartphones? Do they text? What is the role of that smartphone? Is it something that's attached to that child's body? Do they even have one? So it's really important that we understand the role of smartphones and where they fit within that family. We also want to think about other communication tools. Are there other ways that children communicate and families communicate with each other? As an example, for young people with developmental disabilities, there's the Go Talk communication device that allows young people to communicate in a way that they are unable to do without that device. And this is a device that's used often in schools. And do they have access to that at home? And then the PEX board, which is really that picture exchange communication system where young people can communicate using pictures. There's a young man who actually wrote a book using a PEX board, and his mother really translated that. It's a pretty cool book, by the way. All right, next slide, please. And we want to remember that healing is not just about the formal medical world. When we're talking about children, these things are really healing, and we want to make sure that we're including them in the conversation, right? So for children, healing is routine and structure, right? It is movement and making sure that that there is some movement within the course of their day. That sleep is important. That a lot of young people struggle because they don't sleep well. And if we could get to the bottom of why they're not sleeping well, that can be really important for them in the long term. Breathing, making sure that they know when and how breathing can be really helpful, like in a school situation and calming the waters, that there's some consistency in their day, that predictability, which is really important for children with intellectual and developmental disabilities, but it's also important for all children. That we figure out how to laugh, right? Laughing is healing for the body. It's really important that we use laughter, and that families understand the importance of laughter, and that storytelling is part of the work that families understand. So we want to get to the bottom of whether or not these things are existing within the home. Next slide, please. Okay, so for folks who don't know, there's other mobile response learning opportunities. They include, in fact, we have a good one coming up next week on, it is on data, and we're going to talk to some folks who really know and understand data. If you haven't joined us for the NASHBIT and SAMHSA funded technical assistance work, this learning community has been a lot of fun. And so if you're able to join us, that'd be terrific. And then we are in that Quality Learning Collaborative. For this particular presentation, I used a few different references, and these are some of the things, some of the places in which the information came from for all of you. All right, I don't think I am taking questions now, Jen, but although I can, otherwise I'm happy to hand off.
We just stay on schedule. We're a little behind. we can move on to Denise. We are having questions answered in the chat, and if there's time at the end, we can delve into deeper on those questions.
Got it.
I will thank you, Liz, so much, and I will pass this on to Denise. Thanks, Denise.
Thanks, Jen. Good morning. My name is Denise Dickerson. I am actually a clinical supervisor for our crisis response and criminal justice programs at Calvert County Behavioral Health, and specifically Calvert Crisis Response. Next slide. There we go. All right, so for Calvert Crisis Response, we are currently a 24-hour, 7 days a week, 365-day program with 3 avenues to access care. We didn't start that way. We started off, certainly as most programs do, running approximately 18 hours a day and slowly worked our way up to that 24/7 benchmark. Next slide. So our 3 main avenues of care, the hotline, our walk-in crisis center, and our mobile crisis team are all through the single point of access, which is our crisis call hub. That's operated by our dispatch coordinators, who are really kind of our front line of defense. They triage essentially every call that comes through the hotline, as well as every individual that walks through our crisis center. Additionally, they provide all of that background information to our teams as they're being mobily dispatched out, because we are dispatched by our 911 system locally as a first responder unit. So some of the things that we are experiencing here locally that I know a lot of you are probably experiencing with the Maryland security breaches. Some of the difficulties we're having with the single point of access is obviously the expansion for text and chat features. We had been working up to that. And then of course we had this big security breach that has really kind of impacted our ability to further expand on that. But the hope is that our dispatchers will continue to be the frontline defense for essentially ascertaining all of those calls, and that'll be something that'll really be instrumental in our rollout for the enhanced features for MRSS and our child and adolescent and family services. One of the nice features I will say about Calvert County, if you're familiar with our county, it's a relatively small county. We are the largest behavioral health provider here, which means that oftentimes we have a lot of information at our disposal with regards to a lot of the individuals that we're seeing out in the community. Additionally, I'm sure everyone's feeling the crunch of the staffing shortage. So we do a lot of cross training, and a lot of the individuals that work within our crisis services also work within our clinic areas. So sometimes people that we may see in our clinics are seeing familiar faces out in the community on these mobile responses, or if they're walking into our crisis services. Further, when we're talking about our system of support and care, and certainly this is an area where we're going to be building out, especially as we're looking at the continuum of crisis services, MRSS, and the follow-ups. We have systems in place because, again, we're a small county and small agencies of both internal and external referrals and formal relationships with outside programs. So we have the great EHR. We have one that's called Aura that actually allows for the ability to make referrals internally within case management programs, different treatment programs that we offer. It's really been eye-opening, considering I'm sure we all have gripes about our own electronic health records, but this one has been really user-friendly and has provided a lot of resources that I know I've been through at least 3 EHRs here that haven't been available to us before. And then relationships that we've had in the past with other agencies, other case management agencies, other supportive employment agencies, things of that nature, ones that we've worked with outside of just a crisis realm, we've been able to expand those services to also support what we're doing in our crisis work. Next slide, Jen. this is essentially just kind of the illustrative view of how our crisis call hub works in that single point of access. It's a simplified version. Go ahead with the next slide. So I know this is me basically preaching to the choir with the treatment on demand model. And what I really wanted to kind of highlight here that I think was talked about earlier, I think Maria mentioned it, is the access to medications and the psychiatric consultation. So our crisis team was actually born out of the opioid epidemic, and access to medication-assisted treatment is really a cornerstone of the work that we do. So from the very beginning, when we launched, medical providers were actually part of our team. So that was really just in the form of initiating, bridging, and continuing medication-assisted treatment, primarily through buprenorphine-based medications. And that was primarily through our funding sources. However, as time has gone on, we've been able to secure additional funding, and then obviously the need was there. So we've been able to shift and expand our resources and our services to encompass all behavioral health crises. And now we actually have providers that are not only able to prescribe and continue MAT, but also consult for psychiatric issues. This is in the form of either medical providers that are board certified, or having nurse practitioners that do specialize in child and adolescents. Again, this is one of the perks sometimes of being in a small area, is that many of the individuals that work within our clinics and within the agencies are also on staff or on call within the hospitals that are local to us. I know that not everybody has that luxury, but that's certainly something that has definitely been a benefit to us. And I think that as we move into more specialized training and treatment for child and adolescents, it's going to be something that's really going to be helpful and become more used. Next slide, please. So on that note, let's talk a little bit more about what our team composition looks like. And it's not always all those people. Next slide. So traditionally, we have operated in a 3-man team, and that looks like this. So we have a peer support specialist, so someone in long-term recovery from a behavioral health issue. And this has certainly expanded over the years. I know that traditionally we have always thought about peer support coming from a place of substance use recovery. And I'm happy to say that we have been able to really expand our peer support program, not only within the crisis services, but also within just our agency, where we have a number of peers with a lot of different backgrounds. And I think that really makes it rich and allows for individuals to really have peers that are more specialized to the crises or the issues that they're having. And because the network, again, is sort of small, it also allows people to, if they're not meeting the peer at the moment that they're having the crisis, they could be handed off to the person that may be most appropriate to them afterwards for follow-up. So that's really been a benefit. And one of the things that often happens is the peer is most of the time the first person that's making contact, and often the last person that's talking to our clients. And there's always that informal relationship that has started, even though we may hand off our clients to case management or other services. Peers seem to be the ones that maintain that long-term relationship of support, and they always are those ones that fall back and are the people that people reach out to. So peers have really been a tremendous asset to our team, and we are really glad that we started that and really expanded that program. We have therapists, and that's in a variety of different ways. As I start to think about how we're going to implement MRSS, it makes me so happy that we look at all of these different levels of education and licensure, because again, going back to the idea of staffing shortages, you know, it's something that we struggle with here, but we've had a lot of success with using a lot of different education levels. And then our medical providers. So for us, we do medical providers in a few different ways. It can either be in the form of someone who is actually able to prescribe medication, so either an MD or an NP, or there's a nurse on shift with one of those prescribers that is available on call for each of those shifts. At present, we operate in 8-hour shifts, and 7 days a week. During our morning and evening shifts, we have two teams available. Next slide. These are our beautiful vehicles. We're really excited because our Tahoe, the SUV in the top left, was just added in the past year, which allows us to be mobile during bad weather. We still have some roads down here that don't get cleared and aren't necessarily paved, and I'm sure a lot of you guys have that in different parts of the state, so not always the thing that we think about. The van on the bottom acts actually as a mobile clinic, and that's really helpful for providing safe spaces, especially when we're talking about kids and families that may need to be separated or have the ability to have a space outside of their home. Next slide. We all have similar mottos. My presentation always has lots of pictures because my team loves to take pictures. So here's the van on a beach. Next slide. So again, most of these services are part of most of the crisis programs. I did just want to talk briefly. Liz talked about tools that are used out in the field, and I kind of wanted to touch base on that. We have been lucky enough to receive kids crisis bags, and that's something that we keep on all of our vehicles. So those are similar to the soothing tools that Liz spoke about. That actually came about by a community project that was donated to us initially, and then it was picked up by the local LBHA. But these bags had a variety of different mechanisms for soothing kids that were in crisis. So we keep them on the vehicles in our centers for walk-ins, but they have things such as weighted blankets, fidget toys, communication tools, whiteboards so that people can write on them, noise canceling headphones, Play-Doh. It was also a way for us to insert logoed materials. So we might put a fidget toy that has, Calvert Crisis Response and our phone number on it. We put coloring books in there with crayons that had our information on it. So it was a great way to give kids something to occupy themselves while we're actually out there, regardless of the crisis, but also leave them something that gives them a way to connect with us afterwards. We also had to think about, a lot of those bags were kind of geared more towards younger children. So we had to kind of expand on that idea of how are we going to ensure that all of these tools are available to kids from young ages all the way to teenagers, because we see a variety of different age groups. And the tools that we're giving them need to be taught appropriately. So for instance, breathing skills, you want to be able to teach kids to do those on an age appropriate level. Mood tracking tools. We carry paper charts around because those are much easier for younger kids and ones that can be done with stickers or by drawing on them. But now we have apps and list of apps that we've developed and carry around for older children because most of them have technology and phones. We've even invested in some logoed charging banks because a lot of the kids have that, and most of them have laptops from school. So things that will be constant reminders to kind of check in on the things that are important, but to use the tools that we're also leaving with them. So a lot of this MRSS, and I know that a lot of us are in the same work groups and attending some of the same meetings, but really it's challenging us to think about how we're expanding what we have, but also how are we going to see the kids across that age span. and utilize the tools across and modify them across from very young to the older adolescents and teenage and young adult groups. So those are just a few of the things that we're doing and we're looking at. I think those are all of my slides.
Thanks, Denise. Thank you so much. That was a wonderful local perspective and really appreciated all the pictures and all the information. So that was wonderful. If folks have questions for Denise, please put them in the chat as we go along. We'll probably move right into regional breakouts just to keep us on schedule. Well, I hope everybody enjoyed their time together. And I know it probably went quickly. And if you did make it through all 4 questions, that's absolutely fine. So we'll do 15 minutes to report out. Just keep it tight with the one person that you appointed. In our group, it was the person that had the most corn this summer because not enough people had had enough crabs. So we really couldn't count that. But Fred's going to give us a quick key points from our group. And thank you, Fred.
Sure. Yeah, real quick. So number 1 was about the triage and process information. We are continuing to work on that in Allegheny and Garrett County. We weren't sure. I brought up the point about, do we need to incorporate 988 into there because that's the new state number that's going through. We're concerned that there might be, we don't want to delay things. So initially we had it as 911 or our EMS system. So we're hoping that we can maybe continue that, at least in the initial stages, and then eventually 988 will be linked in with an immediate transfer to local 911 call centers to not create a delay with dispatch. But it was great to hear that Calvert County, I think, said they're still using the 911 EMS system. So that was wonderful to hear, and it gave us some good. I think Sharon said she was going to maybe get some clarification about the 988 and if we have to include that or make that a requirement in the mobile response. For number 2, the warm handoff, we're still in progress with that. So we'll get that hopefully figured out soon. We'll use, again, some of the wonderful information that Calvert County shared in today's presentation. So we're hoping we'll be able to get that soon, at least with the PowerPoint or the audio video that was shared today in today's meeting. We still do not have so that was the warm handoff. The role of the assessment play in the initial response engagement. The electronic health record would be nice. There was a comment made about using previous history, which would be good to know. But for a brand new person, I guess we're relying on we want to have a very experienced person to do the crisis assessment, at least if it involves an initial phone call. We're going to clarify that with some additional discussions with the Innovations Institute and also with Sharon as we, in our final preparations for the RFP to be provided to individuals. And we've been using a lot of the PowerPoint presentation and information to help with the continuum and the flow charts that have been used from the initial triage through the assessment and then the initial 72 hours up to the 6 to 8 weeks for all that. Integrating peers for number 4, we view that in Allegheny and Garrett as essential. We're a little concerned about what the requirements will be for peer recovery specialists. We're hoping that it will not mandate that they have to be certified prior to being included in the initial mobile response. We'd like to see peers included in all phases of mobile response up through the initial, maybe even in the triage and through the warm handoff, and especially with the follow-up over the 6 to 8 week time period, if that's possible. I know recruitment has been extremely challenging in Garrett County. I'm not sure about Allegheny for peer recovery specialists. And I gave the example in our group that it's probably been, 2 months or if not longer to find one peer recovery specialist for our substance abuse treatment program. So it's been challenging and they still are looking. So I don't know if there's any questions, comments, if we're doing that for this, but I think that's about all we talked about. And Jennifer, Sharon, anyone else, please add some other
I
information.
think we're good since we have to get through the other 4 groups. I appreciate the report out, Fred. Our counties were also St. Mary's and Charles, but we didn't have they were newer staff and didn't have Charles present, so it was mostly a conversation with Allegheny and Garrett. But thank you, Fred. I think we'll move on to the next group, number 2, which includes Howard, Baltimore City, Baltimore County, and Carroll. And if we can have that representative step forward and report out 3 minutes of highlights. Did you have a spokesperson for group number 2?
Dr. Di Pasquale is going to report out. I don't know if she may be muted.
Yep, I was muted. I apologize. I was trying to find my picture on the screen. I was like, where did I go? So we started our conversation talking a little bit about the 988, just where people, where the counties were with this since it just started to come out. And Baltimore County mentioned that they're doing marketing and outreach, and that they reported out that the current crisis responder had already had 20 calls come in directly to the new 988 number over the weekend. So it seems like people are becoming more aware of it. Baltimore City stated they requested an increase for materials from community providers. GBREC's press conference will occur today. And then they're going to be doing a phased-in marketing approach. Carroll County, they've posted information on social media and will be sharing information in upcoming community fairs, discussing at provider councils, waiting to hear back from the director of a current crisis response team to see if calls are coming in. So then we started talking about questions. And so the first one, what triage process and information. Baltimore County said all existing call centers have their own process, and GBREX is working to develop a shared process as the call center is developed. We had a little conversation in regards to looking at different populations. So in regards to the IDD population, I recommended that Shauna and I get together to talk about how DDA, we have our own specific mobile crisis number for individuals that are in the DDA waivers. However, there are a lot of youth that are not on the waivers yet, or there may be adults that should be on the waivers but don't know about DDA for whatever reason. So, people are still may get calls for those individuals. So we thought it might be good to just get together and look at how to show what processes we're currently using, so that if and when somebody is dealing with an individual that may have IDD and is also having a mental health crisis, that the crisis staff will have some kind of knowledge. So we're looking at, kind of excited about partnering to discuss a little bit about that. Baltimore City, the call center is launching in October, and there are 2 GBREX pilot programs that'll do a soft launch in November. Most jurisdictions don't have a child-specific team, but there is an RFP that's gone out in Baltimore City for a child-specific response. So they're looking at that, and the MRT pilot is including a behavior analysis to address IDD needs. I also mentioned that they might want to look at using a licensed clinician, maybe not just behavior analysis, so that they're opening up the realm of professionals that they might be able to get, because sometimes, especially now with our staffing crisis, a specific, behavior analysis tends to be a bit more difficult. Michelle said that she'll share some examples about what other states are using so that we can look at those. And then how are we planning warm handoffs? Baltimore City, they were not aware that the best practice is to stay on the phone until MRT arrives. Baltimore County just started the 911 call center pilot to assist with ensuring diversion occurs and warm handoffs. And how are we integrating peers? Baltimore County is including SUD peers. It's only limited by funding, not by philosophy. They think it's a great idea. It's just how do we bring that resource in and have the budgeting for that? And that's all we got to.
That's great. That sounds like a robust conversation. So thank you for that. All right, well, we will move on to our next group. And again, it just has to be the highlights of your conversation so we can get through all 5 groups. which I'm sure there are a lot more will be said that you won't share. But the next group is Montgomery, Anne Arundel, and Prince George's. If you can step up to the mic.
So I'm going to be doing the report out. So let me start with Prince George's County has a brand new provider as of July 1. So congratulations, very excited about that. So for triage, a lot of this is Anne Arundel that we're talking about because iMind has been in existence for 27 days and are still getting up and running. So triage calls are prioritized based on severity. We use police radios. Police can radio us directly. Families can call in. Schools, kind of anyone in the community can call in. Our warm handoffs to kind of make families feel connected throughout the process. It goes past when mobile crisis goes out there. We will actually do follow-ups after the visit, make sure that they're fully connected, including providing transportation if they don't have transportation to their clinic appointments or substance use appointments. In terms of the assessment and the role of CAT, we are not using CAT. We do have an electronic health record and a data dashboard. The CAT questions will be incorporated into our existing assessment. So those specific questions for CAT will be included in there. Communication, honestly, is just key in this whole process. In terms of peers, so Prince George's County is using peers in a slightly different setting. With the new vendor, their new vendor is intending to have both mental health and substance use peers. In Anne Arundel, we don't have specific peer positions, but we are fortunate that we do have staff who have lived experience, so just not in a peer position. They're in one of the other positions. But we can refer to, and do refer to, our health department, which has a very robust substance use peer support, and also our Maryland Coalition for Families. And then if parents have mental health issues, they can also get connected to the our local On Our Own chapter for peer support. I think I got everything.
Great. Thank you, Catherine. I appreciate that. And good luck, iMind. We're excited to hear more about your program as well. All right, our fourth group is Midshore, Lower Shore, Cecil, and Frederick.
All right, good afternoon, everyone. It's Shalera from BHA, and in our group, it was pretty unique because it was facilitated by Sarah from University of Maryland. I was present. Midshore had a few staff. Affiliated Sante, which is the provider on the Eastern Shore, 8 counties on the shore for crisis services. And then you had Frederick and Worcester County LBHA folks there. So within this committee, in talking about triage, I think we talked about how Worcester County primarily is using their health department as the provider, and they partner with law enforcement and the crisis response member. And they're called to the scene and trained by the local police academy on CIT model. And we talked about how the suicide-related calls are definitely prioritized and around safety planning. And then with Frederick County, the vendor is Shepherd Pratt, who is also a call center for other types of calls. And then with having the actual provider on in our group, Affiliated Sante, Allison talked about the hotline and a warm handoff and a dispatch team and being able to triage, and then incorporating the MRSS model, and with the youth, always someone going out because the family is defining the crisis. I know in Frederick, we talked about this being a new model as far as looking at all calls being defined by the parent, and as a crisis when looked at. And what role does assessment play in any tools utilized? With Affiliated Sante talked about, there are 2 CARF approved assessments, and within those assessments, there are other evidence-based tools to look at substance use screenings, also diagnostic assessment piece as well there. And it's more of a conversation, which is great, to look at the whole picture, looking at strengths, natural supports, skills, resources, and coping skills. And which peers do we use on teams? And within our group, Affiliated Sante spoke about over the past 2 years, incorporating all types of peers, forensic peers, substance use, specified peers are just a few. And I think that is it. We ended with a few questions that our facilitator will take back to some others to kind of help our group and hopefully others across the state as well. One being about the number of assessments that are required for MRSS, trying to balance that with getting the assessments done with also providing good quality care to whoever the team is serving, and then also about billing for crisis. So that hopefully summarizes our team. If anyone else has anything to share that I may have left out, please fill it in.
Great, Shalera. Thank you so much. That was a really great update. All right, our last group, group number 5, last but not least, Calvert, Harford, and Washington.
And Jennifer, I fell down on my facilitator job and jumped right into the questions and didn't ask somebody to report out. So I'm going to throw myself on it in the interest of time.
That's wonderful. Thank you, Melissa.
But if folks can jump in if they need to. So in terms of the triage information and process, there was a lot of focus on understanding what led to the call and the desired outcomes for the family. So has this been an escalation that's been coming or something that just happened immediately? A lot of reliance on the phone intake processes and understanding triggers. And Denise reported that, they asked demographic and safety questions for callback numbers. And that because they also provide behavioral health services and some of the folks moonlight on the crisis team. Sometimes they have some information already at hand about the person who's calling. In terms of warm handoff practice and policy, some folks reported closely working with urgent care centers to facilitate warm handoffs to EDs or other treatment programs when necessary, and to care coordination. There was an emphasis on the expectation of warm handoff in training and in job expectations, as well as being able to leave notes in the EHR, and an emphasis on really that relationship building to understand the essence or kernels of what's most important to the family and as part of warm handoff. And then several people spoke about the need to facilitate warm handoff and set clear expectations with the family and youth. So not all programs are available 24/7. So being able to flag in the EHR or for follow-up and with the family and youth that someone's going to call you, but it might not be until Monday morning. Texting before you make a call because people don't pick up unknown numbers now, those sorts of issues. Assessment in the initial response and engagement. So we have some folks who are beginning to explore the CAT, but others who haven't employed it yet. Similar to what the last report out said, there were some concerns about the amount of paperwork and introducing new assessments and how to fit those into rapport and trust building in a process, and understanding that it isn't always, and I don't want to put words in people's mouths, but a linear process that it's assessment to diagnosis to treatment in a crisis. And so we need to be thinking about an accurate picture over time, and concerns about increasing paperwork and burden. And again, that interruption of the flow and working relationship and rapport building. And then lastly, in terms of integrating peers into mobile crisis, we have one person who reported that they have a family peer and that it's been a really positive experience for everyone. Another person who reported that they rely on external partners. So they're not on the team directly, but they have good relationship building with peers at the health agency. And then Denise reporting that peers are part of their team and wholeheartedly recommending that and talking about the visible change in people's response when a peer is included in response and in follow-up, and how critical it's been for rapport and trust building. So if I missed anything or misrepresented anyone, please hop in. It's a little like speed dating.
Yes, it is speed dating, and I do apologize. This is the second time I've done speed dating. I should learn to give us more time to debrief after this, so I will remember this for next time. Thank you, Melissa. So we have about less than 15 minutes left to get through 2 other presentations. I'm going to pass it off to Jay, who, Jay, you might want to consolidate or expedite or however you want to do it, just to give at least a minute or so for me to give a TA and training update.
Okay. Well, hello, everyone. Again, we've done actually quite a bit of talking today around data, and particularly the CAT. And some of this we've gone over before. I did want to start out that, I mean, the goal with the data component of this is to create a data-informed state crisis system. And that's going to take a while to put in place. There are many local systems out there that we heard a little bit about today, but pulling that sort of all together in a system that has uniform elements. Can you go back to the first slide? So we're looking at building a system that is a uniform set of data elements, which we have a pretty good set determined now. There's still some work going on to hone in on that, and I'll talk about that a little as we go forward. We want it to focus on outcomes, and that's part of the reason for using this standard assessment tool, among many others, is to get at some direct outcomes from the crisis system. Are we making a difference in people's lives? And we want to get to an individual level data collection system so we can really track individuals, families, youth, adults who move through our crisis system, and what sorts of outcomes are they getting. And second, lastly, we really want to have the data used. I mean, there's no reason collecting it if we're not using it. So really thinking about the structure and what do we need in place that we're really using the data to inform and guide the transformation in the crisis system. Next slide. Some of the measures of success that we looked at, the measures which we don't have time to go into today, will really look at some of the operational efficiencies in the crisis system, time to answer calls in terms of call centers, to, dispatching mobile crisis. We want to be able to look at reduced risks and reduced emotional needs as a result of the crisis services that were provided, as well as what we've talked about before, our success in sort of diverting individuals from emergency department services, inpatient, youth, more restrictive settings, and really dealing with them within the crisis system. Next slide. So a lot of work is going on now. We have a defined set of core crisis measures. One thing that's happening with that, with the implementation of 988, we do understand there are some new data that will be required of all 988 call centers. So we're getting our arms around that now, and that's what we will use for the call center. So it's not going to be sort of in conflict with that. And that's supposed to be coming out, I think, in the next several months. For all call centers will be required to use that. So we're just sort of linking up with that. So there'll be a few more changes to the piece. We're also working on an interim data system to capture monthly data in the interim as we're working toward building a more robust system. In terms of right now, we're looking at developing sort of a system that we can work with and finalizing the functional specifications for the more intensive client level system. We have some basic specifications we worked with IT around. Those need to get built out more. We will be finalizing the data systems in the fall, the specifications and design, and hopefully begin building it. There's a lot of moving parts with this, as you know, and a lot of complications on how all of this will work, what platforms, etc. We're looking at training crisis providers and stakeholders, in the beginning of the new year in 23. Around this system, and then really looking, starting early in the year, but looking at building in sort of a continuous learning and quality improvement process. Next slide. And next slide. We've gone over the CAT quite a bit. I just want to say that the CAT is really meant to support your crisis process. I think Liz hit on this early on. It's not meant to be sort of a extra paperwork, but really to guide your process, to get the information you need to make the decisions around the best course of action with a youth and family. It's not meant to repeat the CAT, but it's really, you're going to be updating it as you move through the crisis process. We have launched trainings in Harford County and in the Midshore region. The first training was in March. A second group was trained in May on the use of the CAT. Again, it was mostly Midshore and Harford County folks. We're expanding that out now. We had John Lyons and his team talked to a large group of folks about the use of the CAT in June, which I think went really well. And then in July and August, we are working on developing an adult version of the CAT. We're close to finalizing that tool, and that will happen probably in August. And then there'll be much more information on that. In the fall, we'll be instituting conduct community of practice trainings for the counties that have been trained on the CAT. We'll also be sort of getting feedback from folks who've been using it to really help us refine the tool and make it fit. Some people were talking about how it fits with your process. And I think it's really important. We want to hear of those people who are using it, how we can adapt it, what things are working, what things aren't, how we can sort of adapt it to make it fit better. And we will be doing another cohort of CAT trainings in September as well. All right, next slide. Number of questions came up. Do I still have time here? Not much.
I think we just have to pivot a little bit in the interest of time.
Yeah.
I think probably we need to take these and I can send out the answers to these questions after the training, if that's okay with you.
That's fine with me.
Okay, so we'll get you answers from the stakeholder meeting in June. These are some of the questions that came up, and we'll send out to this group the answers, and also, of course, make ourselves available for any other questions, given that we have run out a little bit of time, needed about 10 more minutes for this today, and I'm definitely not standing between you all and lunch. So here's the recording to the stakeholder meeting from June, if you want to listen to it. And then I will just take the last couple minutes to give a quick update on training and TA, if that's okay, Jay, with you.
Mm-hmm.
You good, Jay?
Yeah.
Okay. All right. So just a quick update here. We have sort of 3 phases to our TA, well, sort of 4 phases. One is this general TA, which we're providing in this every other month collaborative that you all are here joining. And of course, we have all of these meetings recorded in one place. So I will send that out later. Folks need to catch up back to January. And these were our individual TA meetings, meeting with the local oversight agencies in each of these counties, have had a bunch of initial meetings, and then we've gotten into the second phase, which is completing and walking through the readiness tool to assess where a county is, and an oversight authority is with their MRSS readiness. And then through that information, we'll be setting up TA action plans, which is the next step. So you can see we have met with 9 LBHAs, and we also did a statewide walkthrough with BHA. And just to give a quick overview of that readiness tool, it includes 55 MRSS related indicators that look at assessing need, fit, outcomes, inner and outer settings of a county that's planning to implement MRSS, both the mobile response and the stabilization components. Then it's scored on a 0, 1 to 2, no, working on it, 0, no, well, you can read, 0, 1 or 2, no, working on it, or yes. And tallied up, and we've come up with a range for those 10, including the state walkthroughs of the score of readiness from 22 to 74. It's neither right or wrong in how it's scored. It is not an A to a E in scoring. It's just about sort of having a score to see where you are in your work and in the indicator categories. So if you haven't scheduled that with us, if you're not one of the counties, please let me know, and I'm very happy to schedule that walkthrough with you all. The other really exciting thing that's been happening is the MRSS training curriculum got off the ground thanks to Sarah Quinn, who is on the call today. The first cohort just launched very recently, the 18th through the 21st, and the initial counties that were asked to join included Midshore, Harford, Calvert, and Allegheny, with workforces that are really ready to implement the components of MRSS. Sarah and Kim were the trainers, and about 30 people were trained. This is just to give you a snapshot of that 3-day training. It is a full 3 days. It's still done in a Zoom format. It went incredibly well, and just to give folks a snapshot of what this training entails, you will be getting the slides to today, so you can have this to look at in more in-depth later. Please email me with any TA-related questions for Maryland TA with respect to the walkthrough tool meeting, discussing where you all are with your systems, helping you in any way. And then Sarah is the contact for any training needs for MRSS in Maryland. So please, you'll have the slide deck. You can refer to these email addresses. And that gets us to our resources and any questions. I will stay on the line if anybody wants to put any questions in the chat, and we can answer them later. I will also send out an email where you can please send any follow-up questions related to today or past information, and we can get those answered for you. So with that said, I want to give BHA an opportunity to close with any closing thoughts.
I would just add, if people are sort of looking at the CAT and have questions or want to meet and sort of talk through how it integrates in your site or issues you might be having, please reach out.
Sure, and probably just to thank everybody again for coming and joining and participating in this. I mean, it's continues to be great work that everybody's doing. We're all moving towards this. In some ways, they're baby steps. In some ways, the pace that we're moving as a state is quite rapid. We did do a readiness assessment of the state as a total. So we have that as well. None of us are where we need to be. We're all have a lot of work to do. And again, as Jay said, all of us here on the team and state side are happy to, provide assistance as best as we're able and as quickly as we're able. So thanks again.
Great. Thank you so much. And I'll send out the recording and the slides as soon as we have them ready. Thank you, everyone.
Thank you.
Take care.